This program is brought to you by Emory University.
Good morning, everybody. Happy Friday. Welcome to another edition of Fellows Conference. Our presenter this morning is Dr. Aparna Sajja. Aparna, those that have not yet got to meet her, is a second-year fellow in the clinical track. She joined our program this past summer after a year of fellowship at Georgetown, transferred in for family reasons and just, I guess, just really wanted to be here. And prior to that, she did her internal medicine residency at Johns Hopkins and did medical school and undergraduate at George Washington University prior to that. And as you can see, she's going to talk about a case of aortic stenosis during pregnancy. Dr. Sajja.
Thanks for the introduction, Dr. Williams. So hi, everyone. My name is Aparna, getting right to it. So the objectives of this morning are to examine the hemodynamics of aortic stenosis during pregnancy, review the general management of valvular disease during pregnancy, and highlight special considerations of pre-TAVR planning and TAVR during pregnancy. And we'll briefly discuss bicuspid aortic valves as well. So getting to the case, the patient is a 29-year-old female, G2P1, who presented at 16 weeks of pregnancy with a history of bicuspid aortic stenosis status post to SAVR 2008 with a bioprosthetic valve, who was transferred to Emory Midtown with new onset decompensated heart failure and found to have severe aortic stenosis. In terms of past medical history, so she had an open porcine aortic valve replacement for severe AR with her bicuspid aortic valve in 2008. At that time, she was 15 years old. She's had a prior pregnancy, which was uncomplicated. She was induced at 39 weeks due to her cardiac history and had a C-section then. And then also a history of secondary infertility. She was previously on ovulation induction agents and a history of PCOS. So in terms of the symptoms leading right up to the presentation, she was diagnosed with the flu in March of 2022, so earlier in the year. And then after that, she started having more dyspnea on exertion, up to 8-pillow orthopnea, weight gain, which overlapped kind of at the time of pregnancy. And these symptoms ultimately led her to present to Brunswick during pregnancy. She had an echo done for the first time there, which showed newly severely reduced LV function with an EF of 20 to 25%, critical AS with a valve area of 0.4 and mild AI. So then she was transferred to Emory Midtown for consideration of valve-in-valve during pregnancy. And then these are her medications that she was on. In terms of the presentation, so she was admitted to the CCU. Initially, her vitals were blood pressure 90/65, heart rate of 93. She was satting 96% on room air, breathing comfortably. In terms of exam, so her JVP was elevated to mid-neck. She had a 4 out of 6 systolic murmur at the right upper sternal border, S3, her lungs were clear. And then she did have some phenotypic resemblance to Turner syndrome. She had a webbed neck, low set ears, and she was more or less on the shorter end in terms of height, so 5'1". For her labs, she was anemic, hemoglobin of 10, platelets of 1 teens. She had a normal creatinine, liver chemistries were normal, and then her pro-BNP was elevated at 855. So looking at her echo, here in the peristernal lung, you can see that the LV function is severely reduced. And then zooming in a bit more, we see that the aortic valve leaflets are barely moving. There is trace AI and some mild MR. And then looking at the bioprosthetic valve here, we see that in the peristernal short axis. And then this is the CW of our aortic valve. We see the elevated mean gradient of 56, max velocity of 4.7, which are consistent with severe AS. The calculated valve area was 0.41 centimeters squared. So at this point, we've confirmed that she has severe symptomatic aortic stenosis of her bioprosthetic valve. That was placed 14 years ago, new onset heart failure, and that she's 16 weeks pregnant. So per OB and MFM, they had classified her as WHO class 4, and pregnancy being contraindicated. They deemed her significantly high risk of maternal morbidity and mortality. However, for the patient, this was a highly desired pregnancy and would not consider termination. So then she underwent pre-TAVR imaging, and per MFM recommendations, she was treated with standard precautions as the fetus was pre-viable at this stage. So this is her TAVR CT, and we see that the LV function severely reduced is calculated at 22%, RV function also mildly reduced. And so the clip on the left here is actually another patient for comparison who has a bioprosthetic valve, aortic valve with the leaflets opening normally, and they are not calcified. So as we can see here, these leaflets are opening normally. And then this the clip on the right is of our patient's aortic valve with very calcified bioprosthetic leaflets, which are not opening at all. And this is a still picture of how calcified these leaflets are, so we can see kind of here. So overall, from these images here, her coronaries are low, and we can see that the obstruction to the left main is high with this post that's situated right in front of the left main. Ideally, the post would be more of at a 2 o'clock position, and then the post near the right coronary looks okay. Again, we see the left main right behind this left post. And then this is the angio of her vessels for TAVR planning. She has small bilateral iliac arteries that are 4.8 millimeters in some areas. Typically, the minimal vessel diameter is 5 to 5.5 millimeters. So outside of that, the other issue is that the uterine artery is a major subbranch of the internal iliac artery, and that vascular complications with rescuing would involve an aortic occlusion balloon and no blood flow to the placenta, even transiently, that could result in death to the fetus. So during TAVR, the delivery sheath may occlude the iliac artery depending on sheath size and the anatomy of the patient. However, per OB literature and guidance, the occlusion of the internal iliac artery is generally well tolerated because of the contralateral iliac collateral circulation. So at this point, based on conversation with MFM, it was recommended that she undergo the procedure that would be considered standard of care in a non-gravid patient, given the pre-viable gestational age, severe maternal condition, and so she underwent TAVR, successful valve-in-valve TAVR with an evolute valve placed. There was reduction in the mean gradient from 54 to 10. There was no post-dilation of TAVR due to the surgical bioprosthetic valve that was positioned in front of the left main artery. There was no post-TAVR AR, and the fetal heart rate were normal after the procedure, before and after. There was no additional lead sheeting or gonadal sheeting that were used, and the fetal heart tones were monitored pre and post-operatively, not during the case. And all of this was in line with MFM's recommendations and clearly discussed with the patient as well. So this is her post-TAVR echo. So we see the presence of a TAVR valve in her sternal lung. And then we see no paravalvular leak. Overall, it looks well seated. The leaflets are opening well. And we see a reduction in the mean gradient to 23. The Vmax is now 3.3 off of this image here. And so she had an evolute valve. It's self-expanding. There's less risk for valve fracture. It has the porcine leaflets, which are thinner, and also typically there's lower gradients for the valve-in-valve in this case. So I wanted to review the hemodynamics of severe AS during pregnancy. And before I do that, I'll briefly touch on bicuspid aortic valves. While it's not the main issue with her current presentation, complication of it was the original insult. So it is the most common congenital anomaly present in about 2% of adults. There's variable inheritance with 10% of first-degree relatives being affected, and 20 to 30% when an aortopathy is included. And as we know, the Sievers classification based on surgical specimen is the most commonly used classification. It can be classified as type 0 without any raphe, type 1 with 1 raphe, and then type 2 with 2 raphes. Type 1 bicuspids are more likely to stenose as adults, while type 2 valves will have complications earlier. So of note, the patient's original insult was severe aortic regurgitation, reportedly from her bicuspid valve, without any aortic root pathology at the time when she was 15. And the AR may be related to cusp prolapse, myxoid degeneration of the valve. Usually AS is the most common complication of bicuspid valves in middle age, and only 15% of patients with the bicuspid valve will have a normal functioning valve at age 50. So for women with valvular disease, the preconception evaluation is very important, particularly for this patient, understanding the severity of her aortic stenosis. Presence of heart failure and related symptoms are important predictors of complications. And this exercise stress testing is recommended as an objective assessment of functional capacity if the patient is asymptomatic. And then, of course, invasive hemodynamic evaluation can be considered if there's discordant echo variables. And then the CPETs are generally preferred in women with severely decreased exercise performance. So preconceptual intervention should be considered in women with AS who desire becoming pregnant and meet the recommended criteria for intervention, which we'll go through. The ESC guidelines actually suggest that pregnancy should be discouraged and intervention should be considered before pregnancy in symptomatic patients due to severe AS or in asymptomatic patients with severe impaired LV function and or an abnormal exercise test. So in terms of aortic stenosis during pregnancy, as we know, the hemodynamics change dramatically. During pregnancy, the cardiac output increases by 30 to 50% due to increase in stroke volume, increase in heart rate, and a decrease in systemic vascular resistance. And most pregnant patients with symptomatic AS can be managed medically, with intervention typically reserved for patients with refractory symptoms. TAVR is ideally reserved for the second trimester. And the thought is that spontaneous vaginal delivery carries a lower risk than C-section due to smaller shifts in blood volume, decreased bleeding, and avoidance of preload shifting anesthetic agents, although the C-section is frequently used as a relatively controlled setting and to shorten labor time. So these are pressure volume loops where the x-axis shows the LV stroke volume, and then the LV volume, and the y-axis shows the LV pressure. So in red, we see severe aortic stenosis compared to normal here on the left side. So we see with the fixed obstruction of AS, there's increased afterload, decreased stroke volume. Here on the right, we see what normal pregnancy does with increased preload, increased cardiac output. And then here we see aortic stenosis in red on the left, and then green is aortic stenosis in pregnancy. So there's an increased preload, but there's also a compensatory rise in LV and diastolic volume, and that's limited by decreased LV compliance. And then on the right, we see severe AS, and then in blue, severe AS in delivery, where the preload increases further from relief of IVC compression. There's autotransfusion from uterine contraction, but the really high LVEDP can also mean a really high risk of heart failure. Really, realistically, in the peripartum period, the hemodynamic changes are somewhat unpredictable. There can be an increased afterload due to uterine contractions, the blood pressure increasing, decreased afterload from systemic vasodilation from epidurals and spinal analgesia, and then an increase in cardiac output up to 30% in the first stage of labor, and then up to 80% immediately postpartum. So what is the risk of pregnancy in moderate and severe AS? So in this study, the authors investigated, it's a 2016 JACC study, the authors investigated maternal and fetal outcomes in patients with moderate to severe AS in the multinational ROPAC registry. It's a registry on pregnancy and cardiac disease between 2007 to 2014. The ROPAC is a global perspective observational registry, and it looked at individuals with a peak gradient of greater than or equal to 36 millimeters of mercury, and then 76% of subjects were from resource-rich countries of the European Union or from the US. And so there were no deaths that were observed during pregnancy and in the first week after delivery. However, 21% of the women were hospitalized for cardiac reasons during pregnancy, which was significantly more common in severe AS compared with moderate AS, reaching 42% in severe symptomatic AS. And then pregnancy was complicated by heart failure in 27% of the symptomatic patients. And then children of patients with severe AS had a significantly higher percentage of low birth weight. So this is a forest plot illustrating the regression analysis for adverse maternal outcomes defined as hospital admission during pregnancy. So the odds ratio of women with severe AS was, we see 2.8 compared to those only with moderate AS, and then the severe AS and signs and symptoms of heart failure were significantly associated with a higher risk of hospitalization during pregnancy. The confidence intervals are a bit large here, however, they do pass the 1 mark. And then the forest plots, this is a forest plot showing the regression analysis for low birth weight with severe AS and NYHA class more than 1 at baseline predictive of worse fetal outcomes. So overall, the author summarized that mortality in pregnant women with AS, including those with severe AS, appears close to 0 in this cohort in the current era. Symptomatic and severe AS, however, does carry a substantial risk of heart failure and is associated with higher rates of hospitalization. I did find it alarming that over 50% of patients with severe AS had symptoms before pregnancy in the study, and therefore an indication based on the severe group for valve replacement, emphasizing the need for improvement in cardiac evaluation and appropriate preconceptual and counseling of patients. So this is the modified WHO classification that stratifies the risk of pregnancy in women with cardiovascular disease. Pregnancy is contraindicated in women with WHO group 4 lesions. So that includes pulmonary artery hypertension, severe systemic ventricular dysfunction, so an EF less than 30%, or NYHA 3 to 4. Systemic RV with moderate or severely decreased ventricular function, prior peripartum cardiomyopathy with residual ventricular impairment, severe AS, MS, or severe symptomatic AS, severe aortic dilation with more than 45 cutoff for Marfan's and more than 50 millimeters in bicuspid aortic valves, severe recorrectation, vascular Ehlers-Danlos syndrome, and then Fontan with any complication. So there are 2020 guidelines for cardiovascular considerations and caring for pregnant patients, and they kind of break it down in terms of valvular disease, aortic disease, and then anticoagulation guidance. So we'll touch briefly on the mitral valve as well, since MS is the most common valvular lesion in pregnancy, and it's caused in almost all cases by rheumatic heart disease. So it's the pressure gradient may increase due to physiological increase in heart rate and stroke volume that leads to an increase in left atrial pressure, worsening of symptoms, and then that can also result in atrial arrhythmias. There is a high incidence of reported maternal morbidity. However, maternal mortality in pregnant patients with MS seems uncommon. And there is recommendations for strong consideration of anticoagulation prophylaxis in severe mitral stenosis and the presence of an enlarged left atrium, even without atrial fibrillation. So in the pregnant patient with MS, the aim is to reduce heart rate and left atrial pressure. So beta blockers are relatively safe, and metoprolol may be preferred over atenolol due to atenolol being associated with a higher incidence of fetal growth retardation. Again, caution with aggressive diuretics to avoid reducing uteroplacental perfusion. And then the percutaneous balloon mitral valvotomy is reserved for symptomatic severe MS not responding to therapy. And then MR and AR are generally well tolerated during pregnancy due to significant fall in SVR during pregnancy and reduced afterload. With the AR, there is a physiological increase in heart rate, which may theoretically shorten diastole and reduce degree of regurgitation. And then nitrates and hydralazine are safe, relatively safe to use, and can be helpful for vasodilation. So there are class 2 recommendations for interventions for severe valvular disease. So this is AS, MS, and then severe valvular regurgitation based on criteria that are met by echo. And then also they have to have the presence of NYHA class 3 or 4 heart failure symptoms as well. So this brings us to a very important question. What's the optimal selection and sequence of valve interventions in a young woman prior to childbearing years and during pregnancy? So shared decision-making is very important in choosing a valve. Prosthetic valves are associated with reduced risk of thromboembolism and anticoagulation during pregnancy, but with a high risk of structural valve deterioration in young women. In this study in 2015, patients aged 16 to 39 demonstrated a high incidence of structural bioprosthetic valve deterioration, 50% at 10 years, reaching 90% at 15 years. And the risk was 7-fold greater in the mitral than the aortic or tricuspid position. And then it's also important to consider the risk of second surgery when selecting a bioprosthetic valve at such a young age. The alternative includes a Ross procedure. So that's replacing the aortic valve using a patient's own pulmonic valve or pulmonary autograft. And then the coronaries are reimplanted into the graft, and a cadaveric pulmonic valve is placed into the pulmonic position. So you have a pulmonary allograft. And this procedure is not thrombogenic in general. It provides excellent valve hemodynamics and has therefore been proposed by many authors as an attractive procedure for aortic valve replacement in young women who wish to become pregnant. The operation, however, may be technically difficult if it's not in a center of excellence, and the associated mortality is between 6.6 to 13% in some of the earlier reported studies. So one possibility to have considered in this patient in retrospect is maybe a Ross procedure at age 15, would not have involved any anticoagulation. There's less risk than a bioprosthetic valve in terms of immediate structural deterioration, generally looking at 20 years without problems, and then future mechanical valve after the childbearing years are completed. So this recent JACC study just came out this year, compared long-term outcomes after the Ross procedure versus biological valve versus mechanical valve, aortic valve replacement in adults aged 18 to 50. So quite a big time frame here, undergoing aortic valve surgery. And they looked at California and New York databases between 1997 and 2014. They excluded those with more than one procedure, reoperations, dialysis, and IV drug use. They used propensity matching and looked at 434 patients per group, and the primary endpoint was all-cause mortality. Overall, they found that at 15 years, survival after Ross was 93% similar to that of age, sex, and race-matched US general population. It was significantly lower after biological and mechanical ABR. At 15 years, the Ross was associated with a lower cumulative risk of reintervention and endocarditis compared to a bioprosthetic. And then in contrast, at 15 years, the Ross was associated with a higher cumulative incidence of reoperation, but lower stroke and major bleeding risk compared to a mechanical valve. So on the left, we see kind of that illustrated cumulative mortality for the bioprosthetic and mechanical out here, and then Ross. And then on the right, we see the cumulative incidence of any aortic or pulmonary valve intervention, reintervention It was 30% for biological, 17% after the Ross, and then 7% after mechanical. So turning our attention to mechanical valves, so they offer excellent long-term durability, superior hemodynamic profile, and because durability is a major factor in young patients, they seem to be a reasonable choice for women who are compliant and committed to careful anticoagulation. However, there is a higher risk of thrombosis during pregnancy because of the hypercoagulable state and then the risk for bleeding as well. And then the increased risk of fetal loss, prematurity, low birth weight, birth defects, all due to the anticoagulation. So in terms of the anticoagulation that's recommended, if there is a mechanical valve, each strategy has its advantages and disadvantages in terms of maternal and fetal safety, and there's no strategy that's consistently safe for both. The maternal mortality rate is more than 1%, and serious maternal and fetal complications are common, and that's with all comers, even with the modern mechanical heart valves and careful management. Warfarin is safest for mom, but crosses the placenta and can cause fetal intracranial hemorrhage, fetal loss. It's teratogenic, particularly at doses more than 5 milligrams per day. And when given in the first trimester, is keeping in mind that that dose may change during pregnancy. So neither unfractionated heparin or low molecular weight heparin cross the placenta, but each is associated with higher rates of maternal thrombotic events than seen with warfarin. And if warfarin is taken in doses of more than 5 milligrams during the first trimester of pregnancy, there's a greater than 30% risk of fetal loss or embryopathy. And then with regard to labor and delivery, the use of epidural anesthesia is contraindicated in the anticoagulated patient. The 2018 ESC guidelines recommend planned delivery in women with mechanical valves. So women are usually hospitalized and placed on heparin at 36 weeks and held before about 4 to 6 hours before delivery. And then a C-section should be performed in women who go into labor while therapeutically anticoagulated with warfarin because of the risk of fetal hemorrhage associated with vaginal delivery. So this is a systemic review looking at maternal and fetal risks associated with various anticoagulation regimens in pregnant women with mechanical valves. Overall, they found that the combined maternal mortality and thrombotic complications were lower with vitamin K antagonists, and the recommended INR here was 2.5 to 3.5 throughout pregnancy when compared to sequential treatment and low molecular weight heparin. However, the live births were also lowest in this regimen, not surprisingly. And for women taking vitamin K antagonists during pregnancy, there's a 2% risk of anticoagulant-related fetal adverse events in the study. So overall, have to balance the maternal and fetal risk. There's really no optimal strategy, and VKAs are safer for mother, but low molecular weight heparin is safer for the fetus. And turning to the last kind of section on TAVR during pregnancy. So as of June 2022, this JACC review, there's 7 reported cases of TAVR during pregnancy, successful TAVR cases. So 1 is in a native bicuspid aortic valve, and then these 6 are in deteriorated by bioprosthetic valves. So the 6 patients who underwent a valve-in-valve were aged 29 to 39. They had a variety of valves, Perimount, Magnese, Medtronic bioprosthetic valves, and they underwent successful TAVR and delivery. This is another case report, JACC intervention, successful valve-in-valve intervention with an Edwards Sapien. It was performed at 22 weeks with a good outcome for both mother and baby. So with regards to special considerations of TAVR, there is a huge risk of coronary occlusion, as we saw in this case, and the main predisposing factor is the proximity of the coronary ostia to the anticipated final position of the displaced bioprosthetic leaflets after TAVR implantation. And so predisposing factors for obstruction can include supraannular bioprosthetic valve, narrow and low-lying sinotubular junction, bulky bioprosthetic leaflets, and low-lying coronaries, or even if they've had a prior root reconstruction, and reimplanted coronaries. So here we just see the schematic of an aortic root with a surgical bioprosthesis and then implantation of how a sapien TAVR results in coronary ostium occlusion. So fetal exposure to radiation is known to cause miscarriage, growth retardation, mental retardation, major malformations, IQ reduction. So what are the thresholds? There is reports that at 22 weeks, radiation doses of less than 500 milligrays are not associated with non-cancerous health effects. And the estimated childhood cancer rate at this is less than 6% for all gestational ages. CT is the gold standard for pre-TAVR imaging, and it's generally not recommended if at all. And if it is to be used, should be minimized exposure with high-speed scanning, appropriate shielding, and the general exposure, which each scan is usually about 20 to 50 milligrays. There are reports in terms of TE and IVUS to get some of these TAVR measurements. I'm not sure personally how reliable they are. There are reports out there of about 77% agreement between TE and CTA measurements. In terms of contrast exposure to fetus, the iodinated contrast has not been found to cause any teratogenic side effects in animals. There is a theoretical concern that iodine may alter development of the fetal thyroid. It has been shown to be mutagenic to human cells in vitro, but there's no actual reports to confirm outside of that. There is also uncertainty around the risk of possible fetal effects around gadolinium. The Contrast Media Safety Committee of European Society of Urogenital Radiology has approved iodine and gadolinium contrast for use during pregnancy. However, the gadolinium is water soluble. It can cross the placenta into fetal circulation in the amniotic fluid, and the longer it remains, the greater there is for that risk of dissociation from the chelate and causing potential harm to the fetus. The only prospective study evaluating the effect of the antepartum gadolinium administration has reported no adverse outcomes in 26 pregnant patients who received gadolinium in the first trimester. So more recently, this is a large retrospective study that evaluated the long-term safety after exposure to MRI with gadolinium during pregnancy. And it looked at a universal healthcare database in Providence of Ontario from 2003 to 2015. And overall saw that gadolinium exposure was not associated with increased harm to the fetus or in early childhood. However, gadolinium MRI at any time during pregnancy was associated with an increased risk of a broad set of rheumatological, inflammatory, or infiltrative skin lesions. So this figure just illustrates that among women who had a first trimester MRI, the incidence rate of anomalies didn't significantly differ by the timing of the exposure. With regards to blood thinners with TAVR, heparin, as we know, is safe. It does not cross the placenta. Low-dose aspirin is also safe, and there's no adequate RCTs that study the P2Y12 inhibitors during pregnancy or breastfeeding. However, they're generally not recommended. So turning back to our patient, so she had a good postoperative course to this point. Her echo at discharge show improvement in EF to 45%. Her mean gradient was 17. And 1 month later, her EF fully recovered. Her mean gradient was 23, and her aortic valve area was 1.3, although that was corrected with using similar LVOT diameters. It was 0.6 in the report. And she is currently feeling better at follow-up appointments with minimal symptoms of heart failure per the notes. She's currently at 20 weeks of gestation. From the MFM notes, it looks like the fetal growth appears reasonable, and the delivery recommendations will be finalized closer to delivery. It looks like from their notes, she should be able to tolerate vaginal delivery if it's not a very long labor course. So to summarize, the choice of valve is important in young women considering the type, the anticipated reoperations, anticoagulation, and pregnancy. Preconception to postpartum planning is important in women with valvular disease, and the heart team evaluation is critical, with special considerations for pre-procedural and procedural planning, the risk-benefit assessment for both mother and fetus. And I just wanted to thank Dr. Gleason, Dr. Z, and Dr. Greenbaum with the case. And that's it. Yeah, I welcome everyone's thoughts or any questions.
Thank you, Aparna. It's very good review. Excellent and interesting case. A couple quick, questions, I guess. One sort of just, if I missed this, I'm sorry. What do we end up deciding on for anticoagulation or antiplatelet regimen for her sort of post-procedure, for the duration of her pregnancy?
Yeah, so she's just on aspirin at this point.
And then, and then sort of it leads to, long-term, and this may be, if there's any of our structural colleagues on the line, once, you have a young woman who now has a percutaneous valve inside a surgical valve, what would be the next, presuming this valve will deteriorate at some point, sort of next steps? I assume possibly a reoperation at some point, but are there any other percutaneous options available to her sort of down the line?
This is Adam. I can handle that.
Yeah,
question.
I'll go ahead and take that one. Great presentation, Aparna. I think you really hit all the very important parts here. And to Dr. Williams' point, I think that our congenital colleagues have been much more aware of lifetime management of valvular heart disease than your general adult cardiologist. But for her, I think that given her anatomy with how low her coronaries are and the fact that she ended up getting an evolute valve inside of her surgical bioprosthesis, I think she's going to be, it's unlikely that she's going to have another transcatheter option. Now, if there's, one of the big things that comes up with some of these valves with low coronaries, particularly after surgery, is you get the pinned leaflet height of the TAVR valve, and if it's the evolute valve, it's a taller valve, so the pinned leaflet height is even higher, so it creates this kind of covered tube graft that's pretty tall and prevents blood flow into the coronaries. So, and barring any sort of invention of where we can remove the leaflets from the TAVR valve and put something else, inside. I think that she's probably, a surgical person on the next valve.
Yeah, it's Adam. Can you guys hear me?
Yep.
Yes.
Yeah, she agreed. She really just wanted the baby, really bad, and so she wanted to do anything to keep the pregnancy, and was willing to actually undergo, after the pregnancy and the baby's delivered. She's like, I'll go into surgery. She'll get a mechanical valve. She's okay with being on warfarin. It's just that I think she had such a hard time getting pregnant the first time, and they thought it would never happen again. So they were kind of excited about this, and she's a little bit older now. So she doesn't even have an ideal TAVR result because of the proximity to the left main. We didn't even post-dilated. Her gradients, as you can see, are higher than you would expect for an evolute valve. So this was really put in as a temporary thing to get her through pregnancy, knowing that it's probably not going to last as long. In a different situation, that valve would have been optimized. We probably would have at least post-dilated, if not intentionally fractured the valve to get the biggest valve area. You could argue that I guess you could see what the valve looks like when her circulating volume goes down and see how long she gets out of it. But her plan is to go to surgery and have a mechanical valve.
That's what I figured. Thanks.
Hey, this is Tony Smith with Congenital. So that was a wonderful talk. So we actually got involved with this case very late. I think most of this was done over at Midtown before she met us. And I want to commend the structural team for a great outcome here. I think this could have gone very, very badly. And I think this is pretty much the optimal what we could have gotten at this point. so I met her just a few weeks ago, and yeah, she understands that she's going to probably need a surgical valve afterwards. I think our ideal when we're kind of dealing with these kinds of situations are to try to delay any sort of surgical intervention for at least, ideally a year after delivery, to give her time with baby and all of the related things in that post delivery period. So our ideal will be to probably try to push her out a year. And she's already pretty much agreed for a mechanical valve for her next intervention. So, but no, I think this was a very challenging situation that could have gone very poorly, that I think we fortunately got a little lucky on. Ideally, this, and you touched on this very nicely in your talk, this would have been one of those situations where catching this before she was pregnant would have been the ideal situation. And I think it really highlights the need for successful transition of care and kind of communication with these patients, because so frequently they hear these words of, hey, you've been fixed, your heart condition has been fixed. And they don't understand that there's these long-term complications and things that have to be monitored. So,
It's unclear. Because normally for a valve like this, we would also have them, an adult patient would be on Coumadin to improve longevity of the leaflets, given probably less flow between the outer, the neosynus created now because of the outer leaflets on the original valve. There's some anecdotal evidence that maybe, Coumadin or Eliquis would be better, but in her case, obviously, there's then that added risk to the fetus, and so she elected for aspirin alone. And I think pretty good data, right? Full dose aspirin at least is safe for that pregnancy, so not a bad choice. I think she's on 325. Is that correct?
This is Mahmoud Abdu. Aparna, excellent talk, absolutely fantastic review of this. And I want to echo Tony here. I want to commend the structural team. They did an absolutely fantastic job with her. I saw her in clinic, I want to say a few weeks ago after her procedure. She's been doing well, progressing as expected. I haven't seen her yet since that initial visit. However, I think we will, as all our high-risk maternity cases, we will be involved in her care when she comes for delivery at Midtown. I have a question about the timing of her mechanical valve replacement. When will that happen? And whether or not we anticipate, given that this is a recent valve, is there any hemodynamic compromise? Should we be thinking about temporary mechanical support, things like that? I don't know the answer to those, so just a question I had. So
You're asking about surrounding delivery?
No, for her replacement of a mechanical valve. The later on after her delivery. I think her delivery will be fine, given that her valve is okay now and her grade is good. But later on, is there an option for her undergoing mechanical valve replacement or not?
I think the ideal will be that, hopefully I think we already mentioned this. We'll have to see how kind of things look after she delivers, because obviously she's in a bit of a high output state at this point. I would anticipate the gradients through the valve to be a little lower. Fortunately, she's had almost complete recovery of her function. I think it's much, much better than where it was. So my hope would be that she'll, if things go well, we should be able to have her in pretty good shape by the time she would have her next valve replacement. But certainly with what she's been through, I think you have to be kind of ready for if the proverbial crap hits the fan there during the mechanical valve. As I mentioned, we would probably try to wait at least a year if we could post delivery to do her valve replacement, just to give her time for, really more from the baby standpoint, all of the, if she wants to breastfeed and whatnot in those first several weeks or months.
That's very helpful. That way we can, also hone on our medical therapy and, optimize her as much as possible before that. So thank you.
Hey, this is Man Jokadar. I had two quick comments. The first is regarding the Ross procedure. If you wanted to, it's very controversial, the Ross procedure. The outcomes are highly variable depending on the center. And low volume centers obviously do not perform nearly as well as high volume centers. And the outlier in terms of excellence is probably Toronto General. In their experience, high volume, newer techniques, bolstering the neo-aorta, there may be, in retrospective analysis, you have to take it with a grain of salt, a survival benefit when compared to other tissue or mechanical aortic valve replacement. And in that center, this is a Jack article from a couple of years ago. Again, retrospective analysis, not clinical trial data. You got to take that with a grain of salt. However, the point is that Ross procedures should only be performed at very high volume centers of excellence, and probably not something that should be dabbled in. So that's the first point. The second point is, anytime you're talking about congenital aortic stenosis or bicuspid aortic valve, you also have to consider the aorta and the aortic dimensions and how that applies to your delivery strategy, long-term strategy, etc. So that's something to keep in mind. And then there's a final little very interesting point. About 4 years ago or so, there's some very interesting animal data linking oxytocin with aortic complications, aortic dissection, aortic rupture postpartum. And so when we give someone an induction agent, oxytocin, we're obviously potentially contributing to that. When a woman delivers vaginally, that can also the natural oxytocin. But even with a C-section, you may have to give a little bit of Pitocin. I think it's very difficult not to give Pitocin, oxytocin for the uterus. And then what about breastfeeding for women? Is it safe for a Marfan's patient with a large aorta to breastfeed? And because obviously that releases oxytocin. These are questions that are not yet answered. But I did think it would be important to mention this potential link with oxytocin, because I think it's very interesting. And Aparna, thank you. That was an excellent talk.
Okay, well, thanks again to everybody, and thanks especially to Aparna for an excellent talk, and thanks to everyone else for tuning in and their comments. And everyone have a great day, and we'll see you next week.
The preceding program is copyrighted by Emory University.